Hi, good morning. Today is the third day of the American College of Obstetricians and Gynecologists 2025 Annual Clinical Scientific Meeting. I'm Dr. Susan Khalil from the Department of Obstetrics, Gynecology, and Reproductive Science at the Icahn School of Medicine at Mount Sinai in New York City in the United States. Thank you for joining. Here's a few highlights from the meeting on day 3. First, a study looks at intravenous fluid in labor and delivery and postpartum hemorrhage and blood transfusion. This study's objective was to identify the possible link between intrapartum IV fluid administration and risk of postpartum hemorrhage and bloodstream. It was a retrospective cohort study that looked at patients between 2020 to 2022. That included 4,124 spontaneous vaginal deliveries in patients aged 18 to 55 who were low risk for postpartum hemorrhage. They used logistic regression controlling for confounders. The results were that of the 4,124 hospitals for spontaneous labor resulting in a delivery, 93 or 2.3% were complicated by postpartum hemorrhage. The total IV fluid volume administered was significantly associated with the likelihood of postpartum hemorrhage and transfusion of blood products when controlling for age, gestational age, anemia on admission, use of epidural anesthesia, smoking, COVID-19 infection, thrombocytopenia, length of labor, laceration, and use of tranexamic acid. The use of epidural in labor was associated with a lower likelihood of postpartum hemorrhage and blood product transfusion after controlling for the same confounding factors. Their conclusions were that IV fluid during labor is associated with an increased risk of postpartum hemorrhage and blood transfusion in patients without any other identified risk factors. The ideal amount of IV fluid in labor is currently unknown, and future prospective studies may help guide future clinical practice. The next study is looking at the effect of prophylactic tranexamic acid on bleeding outcomes for dilatation and evacuation. And the goal of the study was to estimate whether prophylactic use of intravenous tranexamic acid decreases the frequency of interventions to control excess blood loss during dilatation and evacuation. This was a randomized, double-blind, placebo-controlled pilot trial. Participants who were undergoing dilatation and evacuation at 16 weeks to 24 weeks of gestation were included. The intervention was 1 gram of tranexamic acid and 100 milliliters of IV fluid, or 100 milliliters of IV fluid alone at the time of the procedure. The primary outcome was frequency of interventions needed to control excess bleeding. The sample size included 74 participants per group to demonstrate a 13% difference in intervention with 80% power, and two-sided alpha for the pilot planned 30 versus 30% plus additional 10% to account for participant dropouts. So those were their estimates for sample size. Their results highlighted that patients that were included were enrolled from February of 2022 to August of 2023. 50 participants were included, 25 in the tranexamic acid group, 25 in the placebo group. 3 participants were excluded post-randomization, 1 from the tranexamic acid group and 2 from the placebo group. They found that more patients received interventions for bleeding in the tranexamic acid group, meaning 35%, than the placebo group, which was about 17%. Bimanual uterine massage and uterotonics were the most common interventions that were used. This table here looks at the demographics of the participants in the tranexamic acid group and the placebo group. Average age was 30 for the tranexamic acid group, 26 for the placebo group. Gestational age was about the same at 19.7 and 19.1 weeks for both groups. 26% received misoprostol in the tranexamic acid group versus 17% in the placebo group. Other notable features here is that 40% were nulliparous in the tranexamic acid group versus 25% in the placebo group. BMI was very similar at 29 for the tranexamic acid group and 27 for the placebo group. and they both had very comparable trainee involvement in the procedure, meaning a fellow or a resident. The complications by intervention group versus placebo group is highlighted in this table here, where blood loss was 556 for the tranexamic acid group versus 415 milliliters for the placebo group. Cervical laceration was found in 13% of the tranexamic acid group and 8%. None of these reached statistical significance in this table. And the measured blood loss greater than 500 was found in 63% for the tranexamic acid group versus 38% in the placebo group. This table here looks at the participants receiving interventions to control bleeding by intervention or placebo, and looks at the different characteristics, number of interventions that were performed. So those that required 5 interventions were about 12.5% in the tranexamic acid group versus none in the placebo group. The most commonly used type of intervention was oxytocin for the tranexamic acid group versus it was widespread after bimanual massage for the placebo group. And the tranexamic acid group had additional findings of fetal demise that were reported and trainee involvement versus the use of general anesthesia as well, and other types of halogenated gas as well. The results also are demonstrated here in these pie graphs that look at the rates of intervention to control bleeding by tranexamic acid versus placebo group, where these are the, on the left, the tranexamic acid group versus the placebo group on the right, and the prophylactic tranexamic acid for dilatation and evacuation does not improve bleeding outcomes based on their findings. The next study here is looking at the management of heavy menstrual bleeding in adolescents within the primary care setting. And the aim of the study was to evaluate existing primary care management and referral patterns for adolescent heavy menstrual bleeding and assess disparities by area deprivation index quartile. Their methods were, it was a retrospective cohort study through chart review. Participants were aged 9 to 16 years of age that were menstruating adolescents who presented to their primary care provider for an evaluation of heavy menstrual bleeding at a single academic institution. 684 patients were identified using the ICD-10 codes for heavy menstrual bleeding. Of these patients, 345 met inclusion criteria. The analysis looked at descriptive statistics and tests for comparisons between the state level deprivation index quartiles. Primary outcomes of the study were initiation of hormone replacement, hormone therapy or prescriptions, or referral to gynecology after initial assessment. Secondary outcomes were heavy menstrual bleeding quantification, hormonal contraceptive discussion. Subgroup analyses were using state level area deprivation index quartiles, which are neighborhood level or socioeconomic disadvantage markers. Results are demonstrated here in this graph here, where heavy menstrual bleeding quantification was documented in 74.7% of patients, including menstrual duration, which was at 63.7%, frequency of product changes at 33.9%, and product use at 17.9%, with no significant differences of the ADI quartile. Results here also show hormonal management was discussed in 74.4% of initial visits for heavy menstrual bleeding, with 32.2% of these discussions initiated by patients or family. In 46.9% of patients, they received a hormonal prescription at the initial visit. Although overall prescription rates did not significantly vary by the ADI quartile, individuals in the 4th quartile had the lowest rate of prescriptions. And then in this figure here, it shows GYN referrals at the first visit by quartile. In total, 10.7% of patients were referred to gynecology after an initial assessment for heavy menstrual bleeding, and there were no significant differences in referral rates by ADI quartile. Their conclusions were that fewer than half of adolescents received hormonal prescriptions, and even fewer were referred to gynecology at their initial visit. And their recommendations were that future work is needed to develop standardized heavy menstrual bleeding management protocols and/or clinician decision aids to guide initiation of hormonal therapy and gynecologic referrals in primary care. The next study that I'd like to highlight from day 3 are risk factors for targeted thyroid screening in pregnancy. Who gets missed? This study was trying to achieve an understanding of the risk factors that warrant screening that would help improve screening practices. Their methods included looking at records for all 1,025 patients who presented for new obstetrical visits in 2020 at a large hospital-based practice in Illinois that were reviewed. Patient risk factors meeting published screening criteria for thyroid disease in pregnancy were analyzed along with thyroid screening status. Data was reported as percentage of patients who actually screened out of those meeting each screening criteria, and the data that's presented separately for screening criteria is endorsed by ACOG and by the American ATA Society. The results were that patients screened meeting ACOG criteria were found to be approximately 32% for those who had a history of thyroid disease. Those who had a family history of thyroid disease were screened at 82%, and those with a clinical suspicion of thyroid disease, none were unscreened. So meaning clinical presentations led to them getting screened immediately. The prior numbers are the ones that I referred to for family history were unscreened. And then those who were unscreened with type 1 diabetes were at 50% from their population. Patients that met screening criteria using the ATA criteria are noted here. Of note, those who have a history of preterm delivery had the highest unscreened rates, approaching 97 or 98% in this visual. The other second group that were the highest for unscreened were age greater than 30, followed by those who had multiple prior pregnancies. Their conclusions were that the most common ACOG risk factor missed was family history of thyroid disease, and most women with an ATA risk factors were not screened. This knowledge can improve the number of patients who receive appropriate screening. Appropriate targeted screening for thyroid disease in pregnancy is underachieved in real-life clinical scenarios. The next study here looks at obesity is associated with elevated chronic inflammatory markers, ESR and CRP, in frozen embryo transfer. Now, nearly 50% of euploid frozen embryo transfer cycles fail, potentially due to chronic inflammation and comorbidities. CRP and ESR are inflammatory markers that may influence implantation outcomes. Obesity is associated with chronic inflammation, elevated biomarkers such as CRP. And this study aimed to investigate the relationship between BMI and elevated ESR or CRP levels in patients who are undergoing frozen embryo transfer. This was a retrospective cohort study that looked at 108 cycles of patients who underwent euploid embryo transfer between March and July of 2024 at a single institution. They looked at ESR and CRP measured at the time of initial beta HCG. Frozen embryo transfer outcomes and BMI obtained were from their assisted reproductive technique database, and elevated ESR was at 225 millimeters per hour, and CRP was 215 milligrams per liter. That's 225 millimoles per hour. And per their prior study that they looked at. Statistical analysis was using t-tests for continuous variables and chi-square tests for categorical variables. They used the R software platform for data analysis. Characteristics of the study sample include average age of 36.3 years, BMI of 29.3, BMI of less than 30 comprised 60% of this population, whereas BMI greater than 30 comprised 39.8% of this population. Those who had a frozen embryo transfer outcome that led to pregnancy were 40.7%, whereas those with implantation failure were 59.3%. The results showed that the study population had the average age of 36.3, just to summarize that, an average BMI of 29.3. Obese patients had significantly higher ESRs. and CRP. Obesity was associated with combined elevated ESR and CRP. Patients with a BMI of less than 30 had a higher rate of ongoing pregnancy compared to those with a BMI of 30, although the association between BMI category and frozen embryo transfer outcome did not reach statistical significance. Multivariable logistic regression analysis demonstrated that combined elevated ESR and CRP was the only significant predictor of implantation failure. Here, this highlights average CRP versus BMI category in the initial table. And in the second table, it shows average ESR versus BMI category. And then in this table here, it shows the association of BMI less than 30 versus BMI greater than 30 with an elevated ESR and CRP versus CRP alone versus ESR elevated alone versus neither being elevated. Statistical significance looks like here is not noted for all three, but overall for the BMI group. And it highlights here that 84% had both elevated markers who had a BMI greater than 30. Only 66.7% had an elevated CRP for a BMI greater than 30, where ESR was only elevated for both BMI less than 30 and BMI greater than 30. And then 76% did not have any elevation for BMI less than 30, whereas only 23% did not have an elevation for BMI greater than 30. Inflammatory markers versus BMI categories just shown here in this visual of the last table, and then frozen embryo transfer outcome versus BMI categories highlighted in the second table noted here on the right, which looks at 70% had ongoing pregnancies and in the BMI less than 30 group, whereas only there was implantation failure in 53.1% in the BMI less than 30 group and 46.9% in the BMI greater than 30 group. Their conclusions were that the study demonstrates a significant association between obesity and elevated inflammatory protein markers in patients undergoing frozen embryo transfer. These findings suggest that obesity may be a key factor in the inflammatory processes that contribute to poor frozen embryo transfer outcomes. Further research is needed to determine if weight loss interventions prior to frozen embryo transfer could improve outcomes by reducing inflammatory marker levels in obese patients. Some next steps include GLP-1 inhibitors before and after and/or steroid treatment during frozen embryo transfer in patients with prior elevated BMI and ESR or CRP. Next study I'd like to highlight is looking at quantitative comparisons of ultrasound versus MRI for uterine fibroid mapping before robotic-assisted laparoscopic myomectomy. Their methods were a retrospective chart review that was conducted to assess patients who underwent laparoscopic robotic-assisted myomectomy for symptomatic fibroids at a single institution by a single surgeon from 2013 through 2023. They looked at imaging, intraoperative, and postoperative outcomes from medical records. They used the Mann-Whitney U-test and two sample t-tests to compare differences by fibroid type between preoperative imaging and operative findings of fibroid number, size, and number multiplied by size, a metric capturing the magnitude of error. Table 1 here just looks at the preoperative characteristics of the cohort. Average age was 37.4 years of age. The racial distribution was non-Hispanic, African-American, 85% of the patients, 2.4% that were Hispanic, 4.2% that were non-Hispanic white, and 7.9% that were non-Hispanic or other racial identity or missing from the record. Average BMI was 29.7. History of infertility was at 39.4%. Heavy menstrual bleeding, 61.2% had this characteristics, where is dysmenorrhea comprised 43%. 35.2% had pressure symptoms, and 21.2% had a history of a prior myomectomy. The type of prior myomectomy was predominantly 51.4% were hysteroscopic, 31.4% were abdominal, and 17% were laparoscopic or robotic assisted previously. The results here just show the intra and postoperative outcomes by preoperative imaging modality. margin of error for MRI. And the mean fibroid weight for patients who had greater than 5 fibroids was 248 grams. Of note, the only p-value that was less than 0.05 was the total cell saver volume, where for subserosal fibroids, it's 187 milliliters versus 100.6 in patients who had less than 5 fibroids that were subserosal. Other values did not achieve statistical significance just in this cohort, but this highlights the various results with subserosal versus intramural versus submucosal fibroids that are undergoing these imaging modalities. Their findings that they want to highlight were from this table was that an absolute margin of error greater than 5 between MRI and operative number of subserosal fibroids was associated with a higher volume of transfusion. Again, this visual here shows additional findings where it's a violent plot of differences in mean fibroid number, size, and burden between preoperative imaging and operative pathologic findings. Their conclusions were among patients who are undergoing laparoscopic assisted robotic myomectomy. They observed minimal differences in the margin of error of ultrasound versus MRI and preoperative mapping of fibroid number, size, and burden. The MRI tended to underestimate the number of submucosal and size of subserosal fibroids relative to the ultrasound. Thank you so much for your attention, and I hope you've enjoyed these highlights from the American College of Obstetrician and Gynecologist Annual Clinical Scientific Meeting for 2025. Thank you for your attention.